and be respectful of everybody's time while he's still letting people in from the waiting room. Sometimes that process can continue on for 4 or 5 minutes after the session, so we'll kind of go from there. Give me just 1 second and we will. So I want to welcome everybody to the March edition of the JVS Online Journal Club. We're really excited to have 2 interesting papers this month. One, of course, is going to be the long-term outcomes of elective endovascular versus open repair of popliteal aneurysms in the vision database. But then I'm interested in the neuro-ophthalmic outcomes after carotid intervention for ocular symptoms. And I think this was something really interesting to review and to have in our journal this month. So we have our 2 host institutions, Houston Methodist DeBakey Heart and Vascular Center. Dr. Eric Pedden is here. He's been here before. Love having the Methodist group here. And then, of course, from NYU, also not their first time, not their first rodeo with us at the JVS Online Journal Club. So Dr. Sadek and then his fellow Dr. Ray will also be presenting. From Houston, also Dr. Watson is their PGY2 resident who will present. It's very exciting when we have our authors here. This is one of the highlights for us. And so Dr. Adrani Sen and Dr. Sen, was your co-author able to make it? I didn't see her come on yet, but.
No, she's stuck at work. She's
Okay.
year 1, unfortunately.
Okay. I totally get it. She's a first-year family medicine resident.
She is?
So I thought that was sort of interesting as a contributor to our journal, very excited, but from Mayo Clinic. And then, of course, our other author guest, Dr. Ochara from Yale, and then one of the PGY2 residents from Stanford, who was a medical student when this work was originally done, Dr. Satam, who's also been with us before. So we have our 2 special guest moderators, which I really enjoy having and I think is always helpful. Dr. Vic Kashyap, who is Vice President and the Department Chief for Cardiovascular Services, now at Cornwell Health, associated with Michigan State University. And then the Chief of Vascular Surgery, Chief Revenue Officer, Associate Chief Quality Officer from the University of Kentucky, Dr. Zenos is also here with us. So very grateful to have 2 moderators helping us. We ask that you do stay muted. You can put your comments and questions in the chat. The moderator for each paper will go through those and address those questions with the authors. The event is being recorded for on-demand access. And then as you are joining us now for the March version, but in April 9th at 6 p.m. Central Time, we will have our April JVS Online Journal Club hosted by the Carolinas Medical Center, and that is St. Louis University as our other group. And the dates are all on vascular.org, but in case it hasn't become apparent, we do these the second Wednesday of the month at 6 p.m. Central. We do not have one in June, given that we all go to the vascular annual meeting. And so that is one time when we will be skipping that month. So at that point, I will stop sharing my screen and then we will turn it over. And Dr. Sadek, do you want to get us started?
Sure, absolutely. Thank you again, Dr. Humphries, for the opportunity. Thank you, Dr. Kashyap and Dr. Zenos for moderating. I'm going to share my screen. And then let's share that and we'll get this up there too. And I trust everyone can see that. And I also want to extend a special thank you to Dr. Ray, who is our first-year vascular fellow doing an outstanding job and will be presenting this particular article. There are no relevant disclosures for this component of our talk. And as you can see, this was an editor's choice, so clearly a well-written manuscript by Dr. Satam and a number of colleagues across multiple institutions across the country, a truly collaborative effort. It was presented at the Vascular Endovascular Surgery Society at their 47th annual meeting. And again, it goes over the long-term outcomes of elective endovascular versus open repair popliteal artery aneurysms, taking advantage of the vision database. Very briefly, popliteal artery aneurysms, they're the most common peripheral arterial aneurysm. And when they present with acute limb ischemia, it's particularly bad, upwards of 25% major amputation rates. There has not been a huge amount written about them, even though we all treat them quite a bit. The largest series out there previously was from the VA by Johnson and colleagues with senior author Dr. Sadawi. They looked at 583 open repairs in 537 patients in the VA system. And when they looked at elective versus urgent repairs, it kind of corroborated the findings. 1 year patency was markedly diminished in the urgent repairs versus elective at 69% versus 100%. Major amputations also went up to 16%. And pretty much everything else wasn't so great either. Survival, poor survival is associated with this at 86% out to 5 years. And if you're dependent, functionally dependent, as opposed to independent, you also did more poorly. But what about for elective cases? There's a little bit of controversy. Do you use vein? Do you use prosthetic? Interposition, bypass and exclusion? Or do you just go ahead and do a stent graft, endovascular? So the last stab at this was by Curie and colleagues with senior author Dr. Sicard. They looked at 56 repairs, probably the largest series of its kind previously, comparing open versus endo, 41 open versus 15 endo. And the outcomes were effectively the same. You can see the Kaplan-Meier curves are rather similar for primary patency, maybe a trend to being slightly worse for endovascular repair in the long term, but effectively the same, and survival was the same as well. What did differ significantly was the length of stay, with 5 days in the open group versus 1 day in the endovascular group. There was an attempt to do a randomized controlled trial for this particular pathology, but there was insufficient enrollment. So to conclude with this particular paper and this manuscript, it sought to look at the long-term outcomes for OPAR versus EPAR and leveraging the national VQI data sets and specifically the Medicare linked vision database to get those longer term outcomes. So thank you to Dr. Ray, Dr. Satam, and Dr. Shar, who will update us on the latest regarding OPAR versus EPAR. So I'll stop sharing my screen now. Let's just get it over there. Oh.
Hey everyone, my name is Cable. I'm the first year vascular fellow at NYU. Thank you, Dr. Sadek, for the warm introduction and the background on the article. I'll just get right into it. So I'm assuming everyone can see my slides and hear me okay. Let me know otherwise. So the objectives of this study was really to compare the long-term outcomes of EPAR and OPAR using the VQI vision database. And I'll get a little bit more into the logistics of the database and the different components as we move along. The study hypothesis was that EPAR is as effective and durable as OPAR. So the methods, this was a retrospective review of prospectively collected data in the VQI database. Essentially, they looked at the vision database, which connects to Medicare data through Medicare claims. They looked at elective popliteal artery aneurysm repair from 2010 to 2019. And what's nice about the vision database or the vision section of the VQI is that it lets you look at data past the 9 to 22-month follow-up that's typically captured by the VQI on its own. So you can see a lot further into patients' progression over time courses. The two modules that they looked at were the PVI and the infrainguinal bypass modules. Patients that were captured in the PVI modules were in the EPAR group, and patients that were captured in the infrainguinal bypass module were in the OPAR group. The inclusion criteria essentially was any popliteal artery aneurysm that was treated with EPAR or OPAR. Exclusion criteria were any patient that had a procedure before 2010, since the study started looking at patients that were from 2010 and onwards, any patient that had a hybrid repair, anyone that had an emergent repair, anyone that had a pre-existing history of peripheral artery disease, and anyone that was not enrolled in Medicare fee-for-service, such as Medicare Advantage. So for database review, they looked at the VQI PVI module, as I mentioned, and patients were essentially identified by looking at if popliteal pathology was identified as one of the 4 arteries that were treated in any endovascular procedure that was done. This ended up making up the EPAR group. For the infrainguinal module, the way that patients were queried here is that popliteal pathology was found by seeing if the proximal and distal anastomoses were around the popliteal artery, and these patients made up the OPAR group. Subsequently, they looked at baseline characteristics of patients. This included demographics as well as comorbid conditions that are listed here. In addition to these two things, they also looked at the percentage of patients that were on a preoperative statin, aspirin, or a P2Y12 inhibitor such as Plavix. And then finally, they looked at perioperative outcomes as well as long-term outcomes. So for the perioperative outcomes, they looked at perioperative complications that happened within 30 days after surgery. These included myocardial infarction, which was determined by the rise in troponin, angina, or EKG changes. Any cardiac complication, pulmonary complications, which were defined as anyone having a pneumonia or ventilator need, surgical site infections, renal failure, which was defined by any creatinine increase greater than 0.5 above the patient's baseline, or new dialysis needs. In addition, they looked at bleeding, which included any post-operative bleeding. In the PVI module, this was defined as a hematoma that required transfusion or required any sort of open or endo intervention. In the infrainguinal module, this was defined as somebody that needed a transfusion or had to go back to the operating room. And then finally, the last perioperative complication that was looked at was thrombosis of the repair itself. And then they also looked at perioperative outcomes, and these included discharge to home in terms of their disposition status, the number of in-hospital deaths, post-operative length of stay, and the 30-day mortality. It's important to note that perioperative complications were only collected in the PVI module after September 2016, so the comparisons were really done for after this date. In terms of long-term outcomes, the outcomes that were studied were mortality, reintervention, and ipsilateral major amputation. The ipsilateral major amputation had to be an amputation above the ankle. In terms of censoring, or when data collection was kind of stopped, essentially if the patients were alive at the end of the study, then censoring happened then. It happened earlier if patients dropped out of a certain FFS Medicare enrollment plan or enrolled into a different Medicare plan. Additionally, for reintervention and major amputations, these were tracked using CPT codes in the Medicare database. And if there was no reintervention or major amputation by the end of the study, then patients were either censored at death at the end of the study, or if they had changed or dropped out of their Medicare plan. Finally, they also looked at long-term frequency of the reinterventions after the repair. And finally, they also looked at subgroup analysis. So they compared the EPAR versus OPAR that was done with the GSV as a conduit for repair. They essentially looked at the same baseline characteristics, outcomes in general for this subgroup analysis. What's notable is that the perioperative complication incidence was too low, so they could not do a comparison statistically for this. In terms of statistical analysis, they looked at patient characteristics and perioperative outcomes, and they compared this using a whole host of statistical analyses. Chi-square or Fisher's exact tests were used for categorical variables, Wilcoxon rank sum tests were used for continuous variables, and then long-term outcomes were analyzed using Kaplan-Meier analysis. Ultimately, they looked at the cumulative risk of death, reintervention, and amputation at 1, 3, and 5 years. They also used Cox regressions to compare the hazard ratios of long-term events after OPAR versus EPAR. And then the frequency of reinterventions was also analyzed, and this was also categorized into a reintervention index. Propensity matching was also used, and this is essentially a way for statistical analysis to be used in observational studies to minimize the amount of bias when randomization is not possible. So here you can see for patient selection, essentially 751 patients had an EPAR done in the VQI module. And then about 1,800 patients underwent a bypass in the infrainguinal module. Patients that were excluded were essentially the patients that I mentioned prior. So if they had a procedure before 2010, they had a hybrid procedure, concurrent PAD, emergent procedure, or if they weren't enrolled in Medicare fee-for-service, they were all excluded. In terms of the total number of patients, there were 2,533 patients. About 1,300 were left after all the exclusion criteria was met, and then 197 of these were urgent, so they also weren't analyzed. At the end, they looked at 1,159 patients. In terms of the data and the results, for baseline characteristics, 755 underwent an open repair and 404 underwent an endovascular repair. The EPAR patients were older and more likely to be on a P2Y12 inhibitor before matching was done, as well as after matching was done. Interestingly, the EPAR patients, only 59.1% of them had full functional status. It's unclear the exact functional status of the OPAR patients. And then runoff data in terms of vessel runoff to the lower leg was only available for the EPAR group, and not available for the OPAR group, so this could not be compared. In terms of perioperative outcomes, there's an overall low incidence of complications. There was no difference in MI, pulmonary complications, surgical site infections, or renal complications between the two groups. There was a higher incidence of bleeding in the OPAR group, but this was only before matching of patients. The following, however, were significant after the matching of patients, which is that patients that had an EPAR were discharged home, more likely to be discharged home for their disposition than the open group, and they also had a shorter length of stay. Here you can see the long-term results. Before matching, EPAR had a higher mortality at 1, 3, and 5-year marks. However, after matching, there was no difference in mortality, reintervention, or major amputation ipsilaterally. In terms of the amputation rate, it was comparable. Like I mentioned, I can give the exact percentages later if necessary. This is essentially just comparing OPAR versus for any conduit versus EPAR. What's notable here is that the mortality rate is essentially unchanged or not statistically significant after matching, but this is for OPAR with any conduit. Interestingly, those that did end up needing a reintervention, the majority were likely to have endo reinterventions. The EPAR group was more likely to have endo than the open group, but overall, both groups were more likely to have an endovascular reintervention if necessary. Now, next, the subgroup analysis was also done for patients undergoing bypass with GSV as a conduit. This was 542 total patients. Approximately over 70% of patients that had an open repair were done with a GSV as a conduit. Again, you can see that EPAR group is older and more likely to be on a P2Y12 inhibitor pre-match, and post-match, they're likely to be the same age, but still likely to be on an antiplatelet drug. After matching, perioperative outcomes were measured, and there was no difference for in-hospital death or 30-day mortality, but there was a difference in discharge home and post-op length of stay, which are both lower in the EPAR group compared to the OPAR group with GSV as conduit. And then finally, they did some Cox regression proportional hazards, and this showed that there was a higher mortality actually for the EPAR group at 5 years, and this was before and after matching. At 5 years, you can see here that OPAR with GSV has a lower mortality than EPAR, and at 5 years, there was no difference between major ipsilateral amputation and reintervention. Overall, there was no significant difference in the percentage of patients undergoing reintervention or frequency of reinterventions between both groups. So in terms of discussion, the OPAR and EPAR essentially have similar effectiveness and durability in terms of limb salvage and reintervention in the Medicare beneficiary group. EPAR patients are more likely to be discharged home and have a lower length of stay than the open group. Both groups have a very low 30-day mortality of less than 2%, and at 5 years, the major amputation rate was less than 5% on the ipsilateral side. Of all repairs, about 72% were done with GSV if a conduit was used for an open repair. While currently the SVS guidelines do recommend OPAR with GSV in asymptomatic patients with a life expectancy of greater than 5 years, this was based on studies from almost 10 years ago at this point, and endovascular patency has greatly improved in the last few years. So while there are some limitations to the study that I'll mention, this study does overall show that endovascular approach to this pathology is viable. The runoff data was not available in the infrainguinal database, which I mentioned earlier. That would have been interesting to compare to the open group. Additionally, it was unable to be determined from the analysis the reasons for failure of revascularization and limb loss. So a randomized controlled trial would help kind of bridge the gaps in all the missing data for this this point. Additionally, clinical decision-making and anatomical information was not available in the database as well. So there could have certainly been some sort of bias in treatment selection and what could have driven why a patient was categorized into a certain group. So in conclusion, elective EPAR is durable. It's comparable to an open bypass with respect to limb salvage and reintervention up to 5 years. GSV as a conduit is the gold standard for repairing a popliteal artery aneurysm, and it is associated with increased survival at the 5-year mark as well. Thank you.
Wonderful. First of all, let me thank Dr. Humphreys and Dr. Ronnie for inviting me to moderate this. Dr. Sadek and Dr. Ray, that was a beautiful review of the paper. Let's cut right to the chase. A lot of questions about really, are these two groups comparable? Because I think, Dr. Ray, you've identified that a limitation is the runoff of these patients is not available in our modules. So could we be comparing apples to oranges? Maybe I'll have Dr. Satam or Dr. Char give us a response.
Yes, first of all, thank you so much for featuring this paper and having us here today to discuss it. I think that's definitely a very important point and limitation that we face just using this database. Obviously, I think one of the questions I'm seeing here in the chat about whether patients with poor runoff were more likely to have amputation, we weren't particularly able to study that here, but I'm sure that there was definitely a correlation in that. And then from the open section, unfortunately, since we don't have that data, it's kind of hard to know if that correlated as well and kind of what the differences were there. In terms of patient selection, it's possible, healthier, younger patients are being selected for open repair in this disease process as well as many others, and therefore runoff data might be quite different. And I think something important that we should be able to look at in the future.
Wonderful.
Thank you. Sorry, Curie, great job as usual. Thank you, Dr. Ray and Dr. Sadek for this outstanding presentation. I do think selection bias is a big problem, and there's I don't think there's statistics that can adjust for it. And I think the selection bias is probably giving that increase in survival in the patients who have greater saphenous vein bypass. I don't think it's the repair of the popliteal aneurysm that gave them a longer survival. I think the more interesting data is that the intervention rate in this analysis was exactly the same, approximately 36% at 5 years follow-up. And the amputations rate were very low, were less than 5% or 5% max. So I think both treatment modalities are effective to save limbs, which is our primary goal in this disease process. And especially, these are Medicare patients, so these are older patients. So especially in old patients, an endovascular approach is probably a very good option. Thank you.
Great answers. Let's just continue that thread about anatomy. Of course, Dr. Char, if you've got an isolated popliteal aneurysm, doing a covered stent or maybe a posterior approach is pretty analogous. But what about those folks with really deteriorated SFAs, where you're really doing a fem to below-knee popliteal bypass and excluding that whole segment of artery? Were those patients included in this analysis? And if not, how would we compare those patients to an endo approach?
So that's a great question. So one of the variables in the VQI is the pathology, whether it's isolated aneurysmal disease, arterial disease, occlusive disease, or a combination of both. And for this analysis, we selected the ones that were only aneurysmal, pure aneurysmal disease. So my suspicion is this data applies for mostly patients who have more true aneurysm rather than a combination of significant stenosis and atherosclerosis associated with aneurysms. So your question is very good, but I don't think it applies to that cohort of patients.
Great.
And I think those are much more challenging because their atherosclerotic occlusive burden is higher, and I think their outcomes probably are worse. But good idea for a future study.
Great. I know we only have a couple minutes, so let's go through these quickly. Dr. Hingorani, important question about the vision database. You want to unmute and ask your question?
Sure. I just had a question that we often find that the younger patients are the ones who, for us, we have more controversies because we expect them to live longer. Does this really apply for the younger patients, meaning that you're really looking at patients greater than 65 years old?
Correct. This is mostly, Medicare linked, so it's older patients.
Great. Dr. Cisneros and Dr. Dahlman have a similar question. Dr. Cisneros, you want to unmute and ask yours? Okay. Dr. Dahlman, you want to chime in?
Yeah, it's pretty straightforward. Vic, I'm curious what's improved exactly. A comment was made that there have been improvements in the endovascular repair or postoperative management that would explain some improvement in that performance. Curious what those would be in the last 10 years. If Viabon hasn't really changed, is there something else about this that I'm missing?
I don't think so. I think this is I think the key is there is selection bias, and I think it's an older patient population. I think most of the series that have been published have described a broad range of patients with different ages. But I think this is this is probably the largest series from an N number kind of sample size, and this is what it shows.
Wonderful. Question related to the applicability of this research. Dr. Char, just as you view kind of the hierarchy of evidence, where does a VQI matched with vision, database study land on that hierarchy of evidence?
I think it depends what the question that you're trying to answer. I think it's for this type of research, I think, and for this disease process, I think it's it's not level 1, but it's probably level 2 and 2 to 3, and I think it's pretty good because, as there was an attempt to even do a prospective trial, and it never materialized because of the sample size. So I think the power in this study and in all VQI studies is the sample size, and I think it's pretty reliable.
Yeah, thank you. And I guess as a closing comment, it may be hard to envision a prospective randomized trial in this area, just given the unique group of patients, the fact that it was tried before without much success, and you've shown that maybe associated with not too much difference. So the thought of how you design a superiority or non-inferiority trial would be a little bit challenging. So thank you very much, everyone. I think we're at 7:30. I'll pass it back to Dr. Humphreys.
Perfect.
Thank you very much.
Thank you. Again, it's always nice to have the authors here to help with the discussion too. And so now we're going to shift gears. Dr. Pedden, do you want to give us an introduction?
Great. Yep. Can you guys hear me okay? Excellent. So I'm Eric Peden, Houston Methodist. Thank you guys so much for inviting us to be part of this again. Just returned from spring break, chaperoning a bunch of teenagers in Cancun. So I'm kind of glad to be back. I'm ready for a ruptured aneurysm, easier task. So Jacob's really going to take the lead on this, reviewing this paper with you guys. I got to say, I personally was not too familiar with these authors or actually even the institution, but from the Mayo system in Wisconsin. The authors have published considerably on carotid disease and ocular ischemic syndrome, which again, I personally not too familiar with prior to reading this paper. I think prior to this, people have said, if they're transient visual impacts, perhaps those will be prevented from worsening, or if they're fixed, probably not going to get too much better. But let's let Jacob dive into the paper and give us the nitty gritty on the methodology and results. Jacob is currently doing a year of research in between his second and third years as one of our integrated residents. So Jacob, let's have you take it away.
Great, let me pull my slides up. Okay, guys, I'm going to get started. If there's any technical issues, just go ahead and speak up and let me know. So, hello everyone, I'm Jacob Watson. I'm one of the integrated residents at Houston Methodist Hospital. I'm really happy to be presenting for this online journal club. So this is a really interesting article out of JVS published this month. It's by the group out of Mayo Clinic, Wisconsin, and it was presented last year at SCVS in 2024. As a background, neuro-ophthalmic symptoms classically arise from cortical or retinal ischemia, and the most common cause of visual symptoms attributed to retinal ischemia is carotid stenosis or extracranial atherosclerosis. These visual symptoms and outcomes after carotid intervention are not well studied. The outcomes vary widely based on etiology of retinal ischemia, and the authors do a really good job of breaking it down into 3 groups, which we're going to touch on later. The purpose of this study is to investigate the long-term outcomes in patients with retinal ischemia secondary to extracranial carotid artery atherosclerosis. So just some anatomy review. The ophthalmic artery, the first major intracranial branch is going to be the first major intracranial branch of the internal carotid artery is going to be the ophthalmic artery. And then you see the vast network of collaterals here that exists through the circle of Willis. Here, I just want to touch on 2 major branches of the ophthalmic artery being the central retinal artery, which supplies the retina and the optic nerve, and the posterior ciliary arteries, which supply the optic nerve head. And then another major collateral pathway is going to be via the external carotid artery via the facial, temporal, and maxillary arteries. And then, of course, we already touched on the circle of Willis. So the study design here is that the study was performed over 4 years very recently from 2018 to 2022. It was a retrospective review at a single site. The inclusion criteria involved symptoms of retinal ischemia, as well as 50% ipsilateral carotid stenosis diagnosed by one form of contrasted imaging, being a CTA, MRA, or angiography, and then a carotid duplex. And patients had to have undergone an intervention, more commonly carotid endarterectomy, but also stenting, which in this group, there's going to be more transfemoral than TCAR, but there's some of both. And then there's also a single case of an ascending aortic to common carotid bypass, but we'll touch on that later. Exclusion criteria were non-atherosclerotic causes of retinal ischemia, mostly vasculitis, and patients who did not undergo an intervention. So enrollment, they had 90 patients that were split into 3 groups. Group 1 is something I think we're a lot more familiar with. It's the amaurosis fugax or the TIA. Group 2 is something a lot more rare. It's the ocular ischemic syndrome. And group 3 was a central or branch retinal artery occlusion. I'm going to define these on future slides. The way they broke patients into these groups was based on clinical history exam, ophthalmology exam, and a fundoscopic exam. The primary outcomes of interest were ipsilateral recurrence of symptoms, visual improvement, stroke rate, and survival. So group 1, the amaurosis fugax or transient monocular vision loss. So acute, painless, transient vision loss resolving less than 24 hours, commonly thought of as a retinal TIA. Group 2 is the ocular ischemic syndrome or retinal hypoperfusion or chronic ocular ischemia in the setting of proximal carotid disease. It's diagnosed by the presence of symptoms and one of the following 2. So you either have to have symptoms plus fundoscopy findings or symptoms plus decreased perfusion on fluorescent angiography. And interestingly, I had never really read too deep on this, but they used a test called bright light amaurosis, which the authors refer to as retinal claudication. And that's temporary vision loss after exposure to bright light, secondary to unmet increased metabolic demand of the retina. So in this small sample size of 7 patients, 2 of the 7 had that exam finding of the bright light amaurosis. Group 3 is going to be central or branch retinal artery occlusion, causing a sudden painless vision loss, an afferent pupillary defect, and a cherry red spot on the fundoscopy exam. And then the interventions that were done, we kind of touched on earlier, but just showing the percentages here. So almost 70% of patients were steered towards open surgery with carotid endarterectomy. A quarter had transfemoral stenting, very few TCAR, and then the 1 carotid bypass. But in terms of that carotid bypass, I couldn't find specific information on the decision-making or what group. So maybe the authors can elaborate on that in the discussion. This is a very busy slide, but I just want to highlight a few things. So risk factors are what you would expect: hypertension, hyperlipidemia, smokers, a moderate amount of coronary disease. But another point is that not all patients were on best medical therapy. Many were on aspirin and statin, but notably in group 3, 48% of the patients required escalation of their medical therapy after presentation. Another interesting point here is who did they present to? About 50% presented to their ophthalmologist, and the other half was a combination of ERs, vascular doctors, primary doctors, and their neurologists. So a lot of variation here as well. And I think one of the key points of this study, and something that's identified in a lot of the historic literature, is this time to presentation. So if you look at the whole 90 patient population here, 70% of them presented delayed or after 24 hours. And if you look at every group, it's about 60 to 75% per group. So that's going to be something to touch on later. In terms of who was having warning TIAs, it's the patients who had a more embolic pathophysiology, so group 1 and group 3, whereas the ocular ischemic syndrome, kind of that chronic hypoperfusion, had less warning TIAs. Just some additional data points. Follow-up was varied. It said 0 to 207 months, but median was about 3 years, and they reported no intraoperative complications. So 2 really good figures from this paper. This is going to be the first one. Group 1 reported no visual decline or recurrent retinal ischemia, a single perioperative stroke, so 3% perioperative stroke rate. And a key finding here in group 2 is they reported no recurrent retinal ischemia or visual decline, and that actually 5 of 7 or 71% of patients who were presenting with the ocular ischemic syndrome, which those symptoms are going to be like dull eye pain, diplopia, waxing and waning vision, 70% or 5 of 7 had complete resolution of symptoms on follow-up. The 2 that did not, on their intake fundoscopy exam, had evidence of chronic and advanced disease. Group 3 reported no recurrent retinal ischemia. 4% of patients worsened. There was 1 perioperative stroke, and unfortunately, only 21% of patients reported visual improvement after surgery. And it's, something to point out is, while just under a quarter had improvement, you have to remember that for these patients with central branch retinal artery occlusion, in the demographics, 75% of them presented at greater than 24 hours. The 30-day outcomes in group 1, which was the amaurosis group, there was a single hemorrhagic stroke from hyperperfusion syndrome that recovered in the ICU and was discharged home. In group 3, there was a single death from ischemic stroke secondary to stent thrombosis after anticoagulation reversal in the setting of a massive splenic bleed. The Kaplan-Meier curves and the long-term stroke data shows that the 1 and 5-year ipsilateral stroke rate for the entire population was 2%, with no recurrent ipsilateral ocular symptoms in any group and no ICA restenosis. And the Kaplan-Meier data for the whole population, being all 90 patients, was 93% at 1 year, 92% at 3 years. And then I tried to kind of pull the individual just based on where I thought these lines were. And it looks like they're all, the author commented that there was no statistical significant difference. And I think even though you see one pretty far down here, that's the OIS group with a population of 7. So it looks like they lost 2 patients over that time, but it didn't meet significance. Notably, the authors commented that there was no death long-term from stroke. Cardiovascular was the most common cause, and trauma, cancer, and some other miscellaneous causes. So clinical implications and conclusions. The OIS group had 70% resolution of symptoms, and the authors and their references had some older case series from the 90s and 2000s, which had historically quoted 7% recovery. So a big, big difference compared to those historical papers. Some explanations for that were thought to be in the older series, less aggressive surgical management, more prolonged courses of medical management before deferring to surgical intervention. And then visual improvement in the group 3 or central retinal artery occlusion group was low at 20%. And I think the things to point out there are, like we talked about, the delayed presentation being very common. This is the historic paper they referenced, if anyone wants to screen clip it. And then the final conclusions. Something I thought was interesting was very low perioperative and intraoperative, no intraoperative stroke, and very low perioperative stroke, I think most likely attributed to kind of the smaller sample size. And then no very low symptomatic recurrence after carotid intervention in all 3 groups for visual symptoms. Many of these patients were not on maximum medical therapy and needed further escalation of their best medical therapy. So I was wondering kind of how many had been diagnosed with carotid disease prior and had been maybe screened or had prior duplexes. And then visual recovery from the historic literature in the OIS group with purely medical management is very poor. So that's pushing towards more aggressive surgical management. Some study limitations. It is a retrospective single center study. It's a small sample size for the ocular ischemic syndrome group. And there's a lack of standardized ophthalmology follow-up, even though there was a lot of ophthalmology exams on intake. And then the delayed time to presentation. So kind of thoughts on how this will change my practice. As a resident, I feel like we see a lot of carotid stenosis consults. We're very diligent about screening for signs of anterior and posterior circulation strokes, looking for motor sensory speech comprehension or total vision loss. But some of the more ambiguous ocular ischemic syndrome symptoms could be better elicited. Those are things like dull aching, eye pain, diplopia, photophobia, floaters, things that could warrant a formal ophthalmology evaluation and take a patient who may not have had a warning TIA but is having these symptoms with 50% disease. Are they truly symptomatic or asymptomatic, or what is their risk? This is another paper the authors referenced I thought was really good. We quoted those studies from the 90s and 2000s that had more ongoing medical management before aggressive surgery with poor recovery of ocular ischemic syndrome. And this new meta-analysis from August 2024 with 480 patients shows 93% either improved or did not worsen and only 7% worsened. So that's, I think, also supporting the author's conclusions here. So that's everything I have for today.
Great. Excellent review, Jacob. Thank you so much for that. Dr. Sen, thank you so much for joining us. The paper that Jacob just showed references work from your previous group and yourself, obviously, from reviewing in a larger group of papers, this ocular ischemic syndrome. Maybe you can just start with that, because I would hazard a guess that most vascular surgeons don't think about eye pain as being an issue from carotid disease, and retinal claudication, like those 2 words have never been side by side in my vocabulary before. So if you could just kind of lead off by talking about that a little bit.
Thank you so much, Dr. Peden, and thanks, Jacob, for that wonderful presentation. And thank you to the journal for giving us the chance to present this. That's what I thought too, because obviously I'm about 3 years out in practice and in Wisconsin, and I was just amazed at the amount of ocular carotid things that I was seeing, and nothing fit the book. So that's how this started. And just like Dr. Dahlman presented put in the chat, there are a variety of patients with, say, visual symptoms of many kinds. And just like Jacob alluded, this when we ask, it's not as uncommon as it is in the literature. So and it's almost like I now see at least 5 to 6 every 6 months or so, which is not a small number. Of course, just as with any of these rarer diseases, the collaboration between ophthalmology and neurology and us, I think that's what also sends these patients our way. And as we have kind of started learning more about it, we kind of keep the whole group together. So that's one aspect of it. And that's now most of where the OIS referrals come from. The paper kind of details the diagnosis, but just like Jacob kind of pointed out, the ocular ischemic syndrome, other than the presenting signs, the few important things are that they must have an ophthalmologist who's kind of keyed into this, and then be willing to do this fluorescein angiogram, which takes a little bit of coordination, but once that pathway gets established, then it becomes easier, because a lot of the diagnosis of the syndrome depends on that. And often patients have multiple other ocular problems. They're diabetics, they may have retinopathy, retinal detachment, cataracts. So to actually key in on this and then kind of offer endarterectomy when it may have, not been done in the past for asymptomatic disease per se at that point is a little bit of a challenge, but we do find that patients get better.
Thank you, Dr. Idrani. I think there are a lot of questions in the chat regarding this multidisciplinary team and the collaboration. So how did you get to that? Was that intentional, or is that something that developed organically after seeing patients and kind of developing ties?
It's a little bit of both, because there were about in this area and in this time frame, there were about 4,000 patients in this region with just CRAO and code hits for this, if you put it like so. So it's not an uncommon problem, and I'm not sure if it's just this region which faces it. I talked to one of my fellowship colleagues who's now at Cleveland. He says that, he too sees a lot of this. So I think it's, the same in many places. And once we were more open to, kind of quickly treating these just like stroke, then ophthalmology also got happier with kind of reaching out to us anytime. And that's essentially how that collaboration came by. I think also some of the ophthalmologists and neurologists were younger, so we all kind of joined at the same time, so that helped. So there is a little bit of that. And yes, I would say to Dr. Hingorani's question that yes, they are kind of more attuned to this diagnosis now. And Jacob, the multidisciplinary team has really changed things, because otherwise to kind of get somebody to put on paper that, yes, this is OIS, I'm not going to confidently do that. But to have somebody who's able to do that and who's able to do the fluorescein angiogram quickly, that was very useful. And I think that benefits the patients. And as with CRAO, we now are kind of moving to see if early thrombolysis for these people, because any vision is better than no vision, especially in like the older cohort, even if there is, hand movement. And traditionally CRAO, you are told that, you'll not see anything. So even if it's a 20% chance, that's kind of reassuring. Like, okay, it's a low chance, but maybe it will get better. And for sure, it's protective for stroke. So from that aspect too, these patients need treating. So those are the ways it's changed management. And thank you to everybody else who appreciated the paper.
There was a question in the chat earlier about the timing of the intervention. Do you feel that there is more urgency in patients with central retinal artery occlusion or ocular ischemic syndrome as compared to patients with amaurosis fugax in terms of the timing of the intervention?
I don't think among the three we have any data that can support that. Of course, there is some sense of, I would say, semi-urgency, because I'm sure, as with most practices, it's difficult to get OR time. So to get OR time for something which is, not traditionally a 2-week indication is even a little more difficult. But just for that, I think we don't have enough data. We traditionally think that the stroke risk associated with ocular symptoms is not as high as it is with anterior or posterior circulation symptoms, or TIAs, which I think is true. That way they are, yes, a little bit low risk, but the true ocular risk of it, I think, is lower, but still not something that should be left for 6 months.
And you did mention that in your paper that the central retinal artery occlusion was treated like a stroke with thrombolysis. How practical is it to do that within 4.5 hours according to the guidelines?
Not very practical at all. And especially because the patients come in late. If they do come in early, it's considered, but that's so not the situation in real life.
That's true. Another question is the chat mentioned about differences in outcomes versus withstanding versus CA. Do you have any comments on that?
Yeah, that was a question I also had starting to treat these patients. So that's why we went back and looked at the literature. What literature exists kind of supports CA again. And I wonder if it is because during the CA, we also open out the external carotid. So, that limited eversion endarterectomy again assists with the ocular collaterals. And that's my theory. But the limited data that is published, it supports CA as a treatment option in comparison to CAs. But obviously, these are not RCTs. These are case series at best.
Thank you.
Thank you.
Well, I think we've had a really robust discussion, and I think Dr. Sen, your work has helped us look for something that we may not have thought about. Really, I have to agree, I don't always kind of consider some of this, and I don't know that our ophthalmologists are maybe as aggressive as the ones that you work with. So I'm gonna send an email to my ophthalmology colleagues now, tell them we're happy to help and be available for them. So I want to thank everybody that was here tonight for the March version. We will have our April JVS Online Journal Club that's coming on April 9th at 6 p.m. You can register for that at vascular.org, and there will be a link that's sent out on social media for all of our platforms. Thank you to our host institutions, Methodist, Houston, as well as NYU. We're grateful to have our authors here, and of course, Dr. Kashyap and Dr. Zenos as our moderators. Have a wonderful night, and we'll see you in April.
Thank you.
Thank you.